All right, well, welcome everybody. Just this is another one of our Wednesday, last Wednesday of every month webinar series that we're doing with the Georgia PGA. We want to thank the guys from Team Rehab for being here. Blake Hampton, introduce Blake and let him take it from there, and then let you guys get going. And as mentioned, this will be recorded and posted on the Georgia PGA website, or our library of education that we have going on. So Blake, let you introduce yourself, talk about yourself, what you're doing, introduce Elon, and let y'all take it from there.
Yeah, fantastic. Thanks for having us, Scott and Michael. We really appreciate you guys bringing us on to do a little info session. This is something that me and Dr. Galan have been talking about doing for a little while here, of trying to get out there and doing some injury prevention type of webinars for the Georgia PGA, and hopefully give you some strategies that you can utilize to manage a golfer when they do have certain injuries, as well as kind of who to refer them to when they do inevitably have some kind of injury here. So Dr. Galan is a sports medicine physician with Northside Sports Medicine here in Atlanta. He works more in the South Gwinnett area. And me and him have been working together now for a couple of years. So we've been putting this together for you guys, and hopefully it'll be a good presentation for you. So I'll let him throw up the presentation and kind of introduce himself.
All right. Hello, everybody. Let's make sure the screen gets shared. And can you guys see my screen all right?
Looks good.
All right. Yep. So thanks everybody for having us. I think it's hard to encompass all injuries in the span of about 45 minutes, which is what we've been tasked with today. But Blake and I decided to focus on shoulder and elbow, and certainly open to coming back and talking about other body parts. So this is me, camera editing right here excluded, but you want to go on. I'm a sports medicine specialized orthopedic surgeon. Have been involved in all kinds of sports all the way up to the pro level, but did take care of University of Pittsburgh's golf team at my last position before moving back home to Atlanta. My colleague Blake Hampton, very high-level physical therapist with a specific interest in golf and golf-related rehab to keep people on the courses and playing 18. So what we're going to try to do today is introduce a bunch of concepts. I'm going to talk more about basically an overview of how the shoulder and elbow function, and specifically to golf. And then I'm going to let Blake step in and talk about kind of management strategies. So it's not important that you remember or even fully digest everything that I say, but more to give a primer. So if you notice something when you're out there playing, it kind of makes sense. You kind of recall a bit of it, and you can get yourself to the proper person to keep you healthy, keep you playing. So the golf swing has multiple phases, and each provides a unique opportunity, especially for the higher handicapped individuals to result in injury. So what I look at when someone comes to me and they're having trouble with their swing, they're having pain, they're unable to complete a round in a pain-free manner, is where that's happening and what part of the golf swing. So again, focusing on shoulder and elbow, I like to break the golf swing into the takeaway, ball strike or contact, and then the follow through. These are actually some older pictures from textbooks that come out of California Orthopedic Institute, which is where the gentleman who trained me, Jim Bradley, is now the Steelers head doctor, trained. So these have been passed on, I guess, through the generations. You can see the force load concentration. These are not by any means exclusive, but there's lots of areas. And the most common places to get hurt are the shoulder, elbow, knee, and back, us concentrating on the first two today. So the shoulder's function in the golf swing is to take all that force that hopefully when you're hitting the ball correctly, you're generating through pelvic rotation, and join the body, torso, and that centrifugal or rotational force into a succinct motion of ball strike. Shoulder injury actually becomes more common as you become a better player. Why? Because you're able to generate more force, right? You use more hips and less arms, and you're concentrating that force hopefully at one low point, which allows for that nice clean ball strike that keeps us all coming back. So we need stabilizers to allow us to continue to do this. But when those stabilizers are compromised or strained, that leads to several golf-related injuries. So those are labral injuries, and we'll go over these a bit: shoulder impingement, and then rotator cuff injury or tear are the three main ones that we see in our golfing population. Quickly to go into the elbow, and then we'll jump back to the shoulder. The elbow's function is to assist in a time transfer of that rotational energy. So if the shoulder is the length, the elbow allows for position of that rotation or force in space. The lead elbow is not usually as affected in golfers, right? We want to keep that arm straight from take back until ball strike. So that lessens stress loads. But the trail or dominant elbow is responsible, as the instructor I worked with at the University of Pittsburgh, for creating angles on the take back so we can break them down and hopefully achieve a successful and controlled ball strike. What happens is that as we make modifications, or if we're having a bad day, or perhaps if we've hit a couple too many divots, little modifications can cause big changes in the golf swing, which can result in strain or sprain, sometimes even worse injuries. Three main ones I want to highlight today, and there are of course more, but the main ones are medial epicondylitis, that's commonly referred to as golfer's elbow, so very on tune for today's talk. Lateral epicondylitis, or tennis elbow, and then a UCL strain, which is also the injury that's been made famous or infamous perhaps by Tommy John surgery, especially in overhead athletes in baseball. So medial epicondylitis, medial meaning inside, is a inflammatory process. So if we all take our palms and turn them up so they're facing the ceiling, right, we're looking at what's called the volar or palmar side of our forearm. And if you move your fingers, you can see all kinds of tendons moving back and forth in your forearm and palm. So all the tendons on that palmar or face up palm side of the forearm all converge on the inside or medial side of the elbow, as seen in the picture. And what happens is with repetitive motion, especially think of that trail hand when we're coming down towards ball strike and releasing of angles, you can get chronic inflammation in that area along a common flexor tendon. Another way to think of that is when you move your fingers, you see all those muscles or tendons moving. They all converge on the inside of the elbow, right where it bends. And I'm sure someone in the audience has probably had pain at that area. You get an ache and throb, especially with repeated swings of the club. Lateral epicondylitis, which is more colloquially known as tennis elbow, is kind of the same thing, except this time we're going to point our palms down, and all the tendons on the dorsal fin of a whale, or on the palm down side of the forearm, all converge on the outside of the arm. Now, the inside or medial and golfer's elbow that I just showed you on the last page, those work to flex or bring the hand closer to the face and supinate, right? And the dorsal side work to extend. So the reason this is called lateral epicondylitis or golfer's elbow is because that's usually seen with the backhand, not a motion that we're routinely doing in golf. And lateral epicondylitis is actually a bit more focused. It involves inflammation of a common tendon called the ECRB, or extensor carpi radialis brevis. So folks like Blake know to concentrate a bit more on those areas when you're having some outside or inside pain. I think a more pertinent example is what you see here in this picture. And what we're talking about now is the MCL, or the inside restraining medial collateral ligament. Remember, medial means inside of the elbow. So the function of that is to prevent, again, palms up. We're preventing our arm from going too far towards the thumb side. We need stability. Otherwise, our elbow would kind of dislocate or just keep going out into space. So you can see in this golfer here in this nice picture that was created by the Golf Distillery, if we shallow our club on the take back or bring ourselves too far under our swing line, what's going to happen is we're going to torque open our hand. And you can do that right now on yourself. If you take your arm and fully supinate, or fully bring your palm all the way up and then move from that position towards the thumb side, you're going to feel some stress on the inside of your arm. And that's your medial collateral ligament, or MCL, preventing instability. So repetitive tweaks, maybe you're trying to open up your club face more for a particular shot, but continuing to do this, especially over time with force, is going to cause strain or sprain in that MCL. Fortunately, MCL tears are not too common, at least not complete tears, in the golfing population, but they are a significant source of pain and something that needs to be addressed, usually with rehab. And with proper treatment is something that can usually be treated and have you back out on the course fairly quickly. And just to kind of bring that point home, again, this gentleman is, again, shallowing or bringing his club under the swing line. And I've shown a picture of the inside of the elbow here and circled the medial collateral complex, which is 3 bundles, perhaps a bit outside of the scope of this talk. But suffice it to say that this main anterior front bundle, right, will often be strained or can even have partial tears. Again, most of these do not require any kind of surgical intervention, so you don't need to see me, but something that someone skilled in golf rehab like Blake can definitely take care of. So I'm going to allow Blake to kind of take the stage for a second and talk a bit about elbow-related golf rehab.
Definitely. So piggybacking on what we were just talking about, lateral epicondylitis, which is most colloquially known as tennis elbow, actually occurs 5 times more often than golfer's elbow. The reason for this being that most amateur golfers experiencing the common swing faults like chicken winging that you can see on the bottom left picture, or I'm sorry, on the bottom right picture, which is a pretty exaggerated form of that, or casting, which is an exaggerated form of that bottom left picture, as most of you guys have seen, or scooping, which is kind of the combination of the two at impact. You can see that with the casting position with that bottom left picture, the most common, I guess, fault with an amateur golfer, that they're going to experience this more in the lead arm. And that's because the lead arm, you can see the wrist is actually a bit extended, where the wrist is actually pulling back towards the person's forearm. And that's going to cause, with repetition of somebody going out and hitting a bunch of balls on the driving range or playing golf, repeating that over and over and over is going to cause some irritation to the lateral structures of the elbow that can cause that chronic inflammation to start occurring. So that's something that we definitely want to look at, as well as with the chicken winging through impact. You can also see that the lead arm, the elbow kind of breaks down into the chicken wing, and that also causes that increased extension of the wrist on the lead arm as well for an amateur. So that's going to also lead to that irritation potentially of those lateral muscles in the elbow. The top picture, I'm sorry, you can go back just real quick. So the top right picture, to me, one of the best ball strikers in the game, Colin Morikawa. This is why you're going to more commonly see this in your higher level players that are making a good impact position, is you're actually going to find this on the trail arm. And that's because of that impact position that you see his trail arm is actually pretty extended to make that, or his wrist is extended on the trail arm to make that impact position. So that's not something that obviously we can really correct for, because this is what we want golfers to be doing. But it's something that's going to happen, and that's potentially where you're going to need to send somebody to see me versus these amateur golfers. This may be something that you can try and correct with some of their swing mechanics and potentially relieve the stresses on the elbow to try and get some relief for your player without them having to come to see either one of us. So this is kind of that injury prevention type of strategy. You can go to the next slide now. So some things that you want to check if you have somebody that's experiencing that lateral epicondylitis, and this is all something that you guys can look at with your player to see if they're lacking any of these areas. But we want to watch for the lower body dysfunction. We want to make sure that they're getting a good pelvic rotation at the back. So that can try and avoid some of those casting positions if we're getting a good rotation. Same thing goes with the thoracic spine rotation that you see on the bottom right there, which is basically just your shoulder turn. So we want to see somebody that can get about 45 to 50 degrees of shoulder turn, which would be a good thoracic rotation. That would also lead to decreasing some stress on that elbow, because they're not going to have to cast to try and get that acceleration with the club. They're actually going to be able to perform a good swing. The other thing would be that teaching the lead arm straight, that may not be an adequate coaching strategy for somebody that's having some issues with the elbow. We may actually want them to bend that lead arm just a little bit, especially if they have some mobility restrictions with the shoulder or with the thoracic spine as seen below. That may be something that you might want to teach if their body is not capable of making that full shoulder turn, that we may actually want them to break down that elbow just a little bit to try and relieve some of that pressure with the lateral musculature. Next slide. So not too far. Go back. There we go. So now medial epicondylitis. I left the same pictures up here from the lateral because the same swing faults are also going to contribute to medial epicondylitis, or more formally known as golfer's elbow. because as you can see, the amateur now it's just going to flip. So now we're going to see more often an amateur with a trail arm is going to experience more of the medial elbow issues versus a tour player is going to have more of the lead arm with the medial elbow issues. And the reason for that is just the opposite of the lateral epicondylitis with these swing faults, that somebody that's casting is going to have the trail arm with a pretty flexed wrist. So the wrist is actually going more towards the forearm like this. And you can see that on that bottom left picture there, that the trail arm is flexed quite a bit. Same thing with the chicken wing. As they come through impact, they're going to have a pretty flexed trail arm as well. That's going to just increase the stress on the medial elbow when they do this repetitively over and over again, versus your tour player or higher level, lower handicap individual that has a good impact position is going to have more of a flexed wrist at impact. And that repetitive motion could again lead to this type of injury from repetitive use. Go to the next slide. So again, the things to check are essentially the same thing. We want to make sure that they don't have any lower body dysfunction, that we're trying to generate some good force using the lower body instead of trying to cast with the upper body or chicken wing with the upper body to increase club head speed. The thoracic spine mobility is again another thing that you want to look at, just because if they don't have a good shoulder turn at the back or at the top of their swing, then they're going to probably possess some of these swing faults that are going to lead to these issues potentially. And then you also could look at their shoulder range of motion to make sure that they are able to horizontally abduct their shoulder, which is what you see in the bottom middle there, which is the ability just to bring the arm across the body, as well as their shoulder flexion range of motion. So essentially just being able to reach up overhead. These things are going to be important because if they don't have good shoulder mobility, then they're potentially going to have to compensate somewhere else. And most of the time that's down the chain a little bit. And now we're looking at elbow issues. So I can go to the next piece here. So some of the swing modifications that you all could potentially look at, and probably things that you're looking at anyway to try and help your golfer improve their golf game, is just the weight shifting and sequencing of the lower body. So I've included a kinematic sequence from a K-vest for a tour level golfer. And this is the kind of kinematic sequence that we should see. And you can see in that gray area there in the middle, that's kind of that impact zone. And we want to see those lines stack up like that, where the pelvis is accelerating at its highest point first, then followed by the thorax, which is the chest, and then the arm, and then the club head should be accelerating towards the end at the very bottom at impact. So you want to see the club head speed being the fastest at impact, obviously, but we want to focus more on the body with those other three positions that we're really getting that good sequence of acceleration leading up to impact. You also want to prevent trying to have your golfer casting or chicken wing or scooping. I don't foresee that this is something that you would teach, but I've had a couple of students that have come to me that they are potentially trying to have them cast the golf club. And these are some people that I've been treating for elbow pain. So that's something that we've had to talk about with the golf coach to see if there's something else that potentially you could do to try and help their swing to avoid these positions. So that's kind of where our team approach comes in, that I would be trying to get in touch with you to talk with you about that, because that's definitely not my wheelhouse to try and fix anybody's swing or make any swing changes. I'm just here to address the body issues. We also want to watch for the path and the plane of the club and making sure the player is not coming over the top, because as we know, that coming over the top motion is probably going to lead to casting or chicken winging to try and square the club face up at the bottom and prevent the dreaded slice. And also making sure the lower body's working, that the pass in line and the elbows should start to feel better if you can do these things. And if not, then that's where we probably need to come in and look at doing some rehab and get them going in the right direction. So some modifications that you can make outside of the swing, and this is something that you could talk to your players about. If they are having some elbow pain, you can talk about sleeping positions. Sometimes I've put players in wrist splints to keep them from flexing or extending their wrist at night when they're asleep. There's also something called the straitjacket technique, which is something I've picked up from the TPI training I've done. And they've actually recommended that you put a player wearing a shirt with their arms inside of the shirt. So it kind of holds their arms in by their side while they're sleeping at night. And that way they're not bending their arms up and doing this kind of thing when they're sleeping. If you have a player that travels a lot, carrying luggage, carrying a briefcase, prolonged periods, this can obviously put some stress on the forearms as well, because they're constantly having to grip and squeeze. And if they're doing that multiple times in a week and carrying it around the airport, that's something that we want to be mindful of, that maybe they get a pull, like a luggage with wheels, or make sure they're using a shoulder strap with their briefcase so that they're not having to carry things that long. The other thing you can talk to them about, and I included this little picture here for some workspace ergonomics. If somebody's a desk jockey and they're sitting at their desk on their computer all day, especially in the age of COVID, when we have everybody working from home now, a lot of times their desk space is not set up very well. So this is something that you could talk to them about with positioning at their desk. So I've just included a couple of pictures of some different exercises that I might try and give a golfer. And this is something that you could actually give them. The bottom two on the right are just some stretches for the wrist flexors and extensors. The bottom two on the left are some simple dumbbell exercises that you can use to strengthen up the forearm musculature to try and prevent them from having elbow issues in the future. If they have stronger muscles, then it's going to be less, they're going to be more tolerant to the stress that the golf swing is going to put under it. The top left is a picture of a hammer pronation supination. So they basically grab a hammer and they twist it side to side and rotate the forearm. So that's another good one for the elbow musculature. This guy in the middle here, that's an excessive amount of weight for that, but I'm sure some of you have probably seen this device that you basically attach a little weight to it and then you can roll it up and then roll it back down. And that's another good one just for forearm strength. And this gyro ball is a good one that's kind of a newer device that you use to build up forearm muscles as well. And it just kind of rotates and you try and spin it and it provides some resistance to the forearm.
All right, thanks, Blake. Great stuff. So obviously lots of treatments that can be provided for just three injury patterns that we talked about. So I'll jump into the shoulder, and again, I'm going to try to kind of go through this quickly, but my goal here is to introduce some basic anatomy and functioning of the joint and then talk a little bit about injuries. I think I even included a surgical video. Don't worry, there's no blood. It's all looks like video games done with a camera, but I think it's kind of neat to link the pieces together. So the shoulder is the most mobile joint in the body. All right, there's several layers to that. The first is just the ball and socket of the arm bone and the wing bone. Around that is something called a labrum, which is, gets a lot of street cred in sports, but it's basically a rubbery bumper that goes around the socket, seen there, that holds the ball within the socket. And then on top of that is another term that most are familiar with, is the rotator cuff, which are four muscles which act to compress the ball in the socket. There they are right there. This is an MRI just showing a rotator cuff, and you can see the tendon going in. If you can see my mouse here in this little area, that's actually a pretty high grade rotator cuff tear. Right, so just introducing concepts. The labrum, it's a bumper, right? It holds the ball into the socket, and there's three areas of the labrum that we try to focus on. The top, and in doctor medical speak, superior part, that's mostly athletic injuries, very common in golf. And then the front of the back here. And the difference between the top and the front of the back is the top doesn't impart stability, it imparts function. Whereas if you have an injury to the front of the back, you're potentially unstable and your shoulder can potentially be subluxing or even dislocating. Remember that injury causes instability and can cause either dislocation, or in the referring to the top, can cause pain. So a simple analogy, it's perfect for this. Your ball and socket is like a golf tee. So if you break off a part of your bumper, right? And we've all done this. We've all tried to pick up a tee maybe that someone else left behind and put a ball in it. The ball won't quite stay because it's broken. Same thing with your shoulder. If you've hurt the lining or hurt your labrum, the ball, or in this case, the arm bone, will not stay centered on the tee or on the socket. So kind of a busy slide, but an important one. I just want to highlight the three areas one more time. So anterior, meaning front instability. This is when someone dislocates their shoulder. So hopefully not happening a lot on the golf course, perhaps if someone's had a few too many, but otherwise not something that we routinely see in golf, right? Slap tears, slap means superior labrum, so the top of the labrum from anterior to posterior, and we know those words now. Anterior means front, posterior means back. So we're looking at that top part from front to back, and that's associated with overhead activity such as throwing a baseball or swinging a club. It's also associated with the biceps tendon, which is a common source of pain in the front of the shoulder. And finally, probably my favorite, because it's very, very commonly missed, is posterior instability. So when you have a tear in the back, people don't dislocate their shoulders backwards, not unless there's significant trauma. But what they do have is instability. And the reason that this is so pertinent is that it causes an ache, but one that we can't quite figure out, because the ball may be moving too far to the back, but we can't see it. There's muscle, there's a scapula or shoulder blade back there. So something that we need to be in tune for. So talking a bit more about slap tears, remember that your biceps tendon, which is this structure right here, and it does come up from the big biceps muscle that we think of with Arnold Schwarzenegger, comes in and becomes confluent with the lining of the socket, right? So with repetitive motion that causes strain, you can get a tear anywhere along this area here that's red. You can get a tear, a rip, a strain, right? And what happens is that when we have abnormal forces, and this is kind of a complicated picture, but suffice it to say that a injured or unhappy and inflamed shoulder is going to cause alterations in all these stabilizers, right? What's going to happen is that torsional force is going to cause strain that's going to be focused somewhere along this red area. And we're going to feel that most either before or after ball strike. So throughout our take back or through our follow through. And the reason for that is demonstrated in this picture. So as we do dynamic movements and as we move our arm either up and back or forward and through the golf swing, that biceps tendon is going to twist. And when it twists, it's going to not only pull on itself and cause stress and strain to itself, but also to the top of that lining or labrum that it's attached to. And what can result is a slap tear, right? So the biceps can tear, the upper portion of the labrum can tear, which is that slap tear, or a combination of both can occur. This is an arthroscopic picture, so hopefully everybody's sitting down, but I promise no blood, right? And this is a person laying down. So this is the socket, right? This is the labrum of that patient. You can see when I pull on it, this is my little probe that I'm sticking through a little keyhole incision. You can see that it pulls straight off the top, and the biceps tendon is coming in right here. So in this case, the biceps remain, but he pulled off the entire top of his lining. This was a golfer who did repair and did do well. Just to show you that slap tears come in tons of varieties. This is something called the Snyder classification, but suffice it to say that the anchor or the attachment point of the biceps can either be compromised as in types 2 and 4 here, or the anchor can remain with more of the force taken through the lining of the socket. The treatment for this is rehab, and more rehab, but in kind of recalcitrant cases, what we do is we simply remove the part of the tendon that's hurt. We like to keep tension on the biceps down here, but we like to offload the torn lining. And this is called a tenodesis procedure, very effective. John Elway actually had one of these and won 2 Super Bowls, one against our Falcons. So a very functional treatment for those cases. Moving on to anterior instability. Hopefully you can tell here, and I'll point it out here, that this person has dislocated their shoulder. So again, I hope something we're not seeing in golf, right? More pertinent to golf is during the follow through, right, in the trail arm, we're moving our arm with quite a bit of velocity and force towards the front of the socket. So remember that bumper in the front can be compromised with repetitive stress, and the shoulder is actually pretty amazing. It encounters speeds of up to 2,000 meters per second, which is akin to about 4,200 miles per hour, right? Pretty impressive things if you think about that as being contained within a shoulder joint. So doing that over and over again, especially doing that with improper form, can cause injury to the front of the shoulder. And how we examine for this is quite simple. We take the person's shoulder and we try to move it forward, and we feel for a click or pain, something that Blake and I see all the time. When I do this, I prefer the pictures to the right. I'll actually have the patient lay down and look at me, and what I'll do is I'll put their arm in an extended position, kind of like a take back in a golf swing, and push their shoulder forward. And I always have them look straight at me, because what you're looking for is something called a chandelier side. Their eyes get 3 times as big, and they look like they want to jump for the chandelier because their shoulder's unstable, and your brain inherently does not want a joint to dislocate. So very easy to tease out with the right exam. Touching now on posterior instability. And this is, again, my favorite because it's missed all the time. So what we're looking at now is we're looking at the front shoulder. And the reason is because now we're driving the front shoulder as we follow through into the back of the socket, right? So you've seen this in your players, right? You may have not recognized it, but you've seen it. And this is that deep ache that's difficult to localize. I got this pain I can't quite figure out, but it's deep in there and I can't touch it. And what this is it's the shoulder partially dislocating or subluxing to the back and the brain registering pain. But because it's not coming out, because you have a shoulder blade and a lot of muscles back there, we can't figure it out. So this is something that we need to be vigilant for and looking for. Very treatable with proper rehab, but needs to be identified first. Just a bit on treatment of labral injury. If all else fails, what do we do? Well, it's quite simple. We reattach the bumper. You know, sometimes I think we try to make surgery to be a little more complicated than it needs to be, but we basically re-sew the bumper. And this is a short video. And again, no blood, I promise. But I think it's kind of cool to see after someone's talked to you. So in this picture, what we're doing right now is we're elevating the bumper. This person is laying down. So the central white area is the socket. That thing peeking in from the top is the ball or the top of the arm. And what we're doing right now is we're freeing up that bumper that's obviously way too mobile. I'm going to make a second kind of access hole. These are all, you know, half the length of a dime. And what you're going to see me start doing is you're going to see me start sewing that bumper back on. So we're going to pass a stitch around it, right? And what we're doing is we're creating a lasso to control this bumper, right? And then what we're going to do is we're going to drill a little pilot hole, just like hanging up a picture. And we're going to put in something called an anchor, which is a dissolvable corkscrew appearing device that actually goes into the bone, integrates into the bone. The white thing there is the corkscrew. The rest of it is an inserter that will come out. And that's going to allow us to refixate this torn lining of this person who was unable to continue swinging a golf club. We're going to do that several times. And ultimately what's going to happen is we're going to have those sutures around the labrum and points of fixation, and we're going to have restored the bumper. So now when this person follows through, this is his lead arm, he's not going to feel himself dislocating. He's not going to experience that constant pain. I think we did 4 on this gentleman. And if I would hurry up and pass this one, you'd see the final shot. Right, and there it is. We got a restored bumper. And then the last thing we're doing is just closing the hole that we made to get in there. So I'll skip through that. But basic treatment of labral injuries is, again, rehab, and more rehab. And in those recalcitrant cases, we usually do get patients back within a pretty expedient amount of time. So moving on to the rotator cuff. Again, 4 muscles that compress the ball into the socket, right? And these provide functions of not only compression, but also motion out to the front or overhead. Muscle is not so much important, but there are 4 of them. We call them the sits muscles. You can see them listed there. I like these pictures, especially the kind of wacky looking one to the right here with the pulleys and levers, kind of like a evil genius machine. The reason is because when someone comes in and they ask me, well, what is rehab going to do for my rotator cuff? Well, I explain to them that those 4 muscles are constantly working under reciprocal tension, right? There's all kinds of tears, there's all kinds of injuries. But the long and short of it is when you place too much strain or when a muscle becomes too inflamed, it stops performing its function. So its part of the machine, if you will, is not working. And the other muscles try to pick up the force load. One of 2 things happen. Either you function suboptimally and you remain functional, but with pain, or the other muscles are unable to overcome the deficit and you lose motion, you lose strength, you lose ability to get out on the golf course. So clinical signs of a rotator cuff, and I think number 1 is most important, but we've all seen these. If a patient awakens from sleep when they turn onto their shoulder, that's a hallmark of injury and something that needs to be sent over to rehab to Blake, right? By the same token, the other 2 are a bit more common: difficulty with motion, especially overhead and out to the side. And the last one is where rotator cuff injuries hurt. It doesn't hurt so much straight in the shoulder. That's more of a posterior labrum thing, as I was showing you. It hurts from the point of the shoulder down the side, even all the way to, but not past the elbow. So when it's kind of down the side of this arm, throbbing and aching, we think rotator cuff, especially along with these other 2. The next term that I think most of you have heard, and maybe some of your players have received if they've gone to their primary care physician, is the term impingement. Now, I'll be completely honest, I don't like that word because that's kind of going to the stomach doctor and trying to get a diagnosis. And I say, what do you have? And I say, well, you have an upset stomach, right? That's not very helpful. But what impingement is in the truest form is when there's not enough space for the shoulder to move or function. You see, I've highlighted this area. So just to orient you, this is the ball and this is the socket. And then this is your collarbone, and this is the connection of it to your wing bone. So if you take your arm and place it on your collarbone or clavicle, underneath that is where the ball lives and where it moves. So that space between the top of the ball and your collarbone is called a subacromial space. And what happens is when you have a poor functioning rotator cuff, again, in that analogy, and the machine is not working correctly, the ball starts to move abnormally and will rise up and potentially hit the undersurface of the collarbone because the muscles are not functioning properly to depress it. An example here, and I like this illustration, the next one. So again, in this example, if a person has weakened rotator cuff muscles, we're not keeping the ball compressed and depressed, we're not keeping it down. So over time, there's going to be collision between the arm bone and the collarbone. What ends up happening is we form bone spurs, and that space narrows even more. So we want to prevent this again by rehab, and more rehab, and strengthening those rotator cuff muscles to keep the ball centered in the socket. So treatment of rotator cuff tears, kind of three kinds. Number one, hopefully, is not something we're experiencing on the golf course. That's traumatic. That's we felt a pop and we can't move our arm, right? Obviously, if that happens, we need to see a doctor. Second two are the ones we're more concerned with in golf. An overuse injury is one where over time we continue to do repetitive forces. And acute on chronic is where maybe we've had a little bit of pain and then we go out there and we get really aggressive. We got a new driver and now the function is really lost, right? So some common facts that I tell people about rotator cuff tears, right? Kind of things that you'll hear from me or Blake if you come in, or even rotator cuff injuries. Our tears do not heal themselves, okay? But just because you have a tear does not mean that you ever need to see me, meaning a surgeon, right? You can become asymptomatic and fully functional with a tear, but you need to turn on the muscles and you need to turn on those other muscles to kind of make up for any deficit from a partial injury. Real quickly, just showing you how rotator cuffs are repaired, and then I'll turn it back over to Blake. This is done through arthroscopic or keyhole surgery, just like the labrum, right? We use anchors, which I've already shown you. And the idea is to get the tendon back down to where it belongs. So this is a rotator cuff tear, right? This is me visualizing with my camera. This U-shaped structure should not be there. It should all be down. I shouldn't be able to see under it at all. So what we're going to do, and I'm kind of showing the infographic on the left and then real time on the right, we're going to pass sutures through. We're going to cross those sutures over, and then we're going to tack them back down in this kind of V-shaped or chevron-shaped configuration to bring the tendon back down to bone. It's another view of it, right? So we have a torn tendon. We're placing sutures and anchors through it, and then on the bottom right there, you can see the tendon has been restored to the bone to allow for healing and ultimate function. I'll turn it back over to Blake now, and he'll talk a bit about rehabbing and preventing these injuries.
So one of the easiest ways to prevent these is by looking at some of the injury-inducing swing mechanics. So first, we'll talk about sway and reverse spine angle. When you sway or you have a reverse spine angle, it's going to limit the amount of thoracic spine rotation that you have. So the shoulder turn is going to be limited. And that's going to place more demand on your horizontal shoulder adduction, which on previous slide I talked to you about, where that's the ability to reach across the body, versus if you have a good shoulder turn, it's actually more of a flexion where you're reaching straight up. So that horizontal adduction can put a little bit more stress on the shoulder, just due to the poor mechanics of that plane of motion. Flexion's a lot more easy to perform than horizontal adduction for everybody. So you have a lot more range of motion in that plane of motion than you would with reaching across your body. Shallow swing planes can also cause shoulder injuries, and that's mostly due to that swing plane causing large divots or fat shots frequently. And that's going to cause a sudden decrease or a sudden deceleration of the shoulder, which can lead to an increased strain on the rotator cuff or potentially the labrum. That again, with repetitive overuse over time, could potentially lead to a tear or inflammation or potentially that impingement syndrome that we had talked about previously. Casting is another one. Again, this is kind of like, as you can pick up the theme, casting is a big problem for the shoulder and the elbow, as well as other parts too. And the reason for the shoulder being involved in this is because when you cast, you're going to get a sudden increase in the club head speed, and that's going to have to result in the shoulders decelerating rapidly to get the club into a position of impact. And that deceleration of the shoulders is going to really increase the strain on the rotator cuff, which could cause potential tears. The last one that we commonly see, and this was kind of what the Tiger Woods era, is teaching the forearm vertical on the trail arm. And if somebody doesn't have enough shoulder external rotation, which is that ability to, I don't know if you can kind of see me in my screen, but rotate back in this direction, which is what you're going to need to get that forearm vertical at the top of your backswing. That can also lead to an increased stress on the labrum that could cause stability issues, or potentially, again, a rotator cuff injury, as those rotator cuff muscles work really hard to try and get that last little bit of motion. So we want to be careful with that if somebody doesn't have that ability to get into that position. Next slide for me. So some modifications for the swing: never use an impact bag. I hope nobody's doing that now. I know that was a thing kind of back in the 90s, and it's really terrible for the shoulder. Again, that's like that fat shot where you're really getting a sudden decrease in acceleration from the shoulder that can cause a lot of stress there. We want to work to increase steepness of the swing plane so that we can avoid the shallow swing plane that's going to lead into those really large, long divots or the fat shots. So steepening the swing plane to avoid that increased time with the contact of the ground will be helpful to decrease some stress on the shoulders as well. And again, like I talked about, modifying away from that forearm vertical, so we can think the Fred Couples swing versus Tiger Woods. Fred Couples played some good golf with that elbow kicked out, so I think it's okay probably to teach that a little bit for people that don't have good shoulder motion. So a few exercises here. These are thoracic spine rotation exercises. So these are some things that you guys could implement with your golfers to try and increase the shoulder turn. The common thing that I see is the shoulder turn being limited with the thoracic rotation. A lot of people are very stiff in their thoracic spine, especially people with desk jobs that are in a seated position all day. We tend to get really stiff there. So these are some ideas that you can try and implement with your students to increase that shoulder turn and decrease some of the stresses on the shoulder and the elbow. So again, some injury prevention that you could incorporate into your teaching. And last here, I have some ideas for you for some rotator cuff exercises. We have some bands that we're using in the top left there, doing some different motions with that. The pictures you see with the person pressing the towel against the wall, that's what we call an isometric exercise. So you're activating those muscles without actually moving the shoulder. This is really good for shoulder stability. So if somebody has a little bit of an instability with their shoulder, this is something that we could incorporate. It's a nice thing to do to warm up for a golf lesson too, or before they get out on the range, just to get the rotator cuff muscles firing. The one in the bottom middle is one that I really like with the golf club, especially if you really want to try and teach that trail arm vertical position, that's going to help improve some of that external rotation range of motion. Just make sure that your golfer is not experiencing any pain when they do this. That would be a sign that you don't want to continue doing that.
All right, so I'll just say I was taught a long time ago and given many talks that you should always share something a little personal. So this is my daughter Emma. She's definitely a future LPGA champ here. So she says thanks, and both Blake and I really appreciate the attention and the opportunity to present to you. We're happy to take any questions, and here's our contact info for both of us. So thank you very much.
Gordo, you're muted.
Sorry. Any questions from the audience? If you do, just click on the little hand, jump on. But I will say it's and I didn't expect to see pictures of surgery today. So that was kind of cool. So, but I think it's great information on how PGA professionals can work with you guys in the rehab department to help strengthen the players that they're teaching on a daily basis. So great information and some stuff I didn't think we'd see today. So any questions from anybody?
Yeah, I got one. First of all, thank you guys for your time. I appreciate it. I was just kind of wondering, I kind of manage pain on a daily basis. For me, I have a degenerative L5 and tendonitis in my hips, and I've had that for the last 8 years, and I'm not even 30 yet, so on my way. But is there a better course is that something you think you should get get treated for, go to rehab for? Because I can manage it and play golf. It has its good days and bad days. But what are the types of, ways to help prevent this injury from getting better? And what type of treatment do you think that would be a recommended way to go? Just in
You
general.
want to go ahead, Blake?
Sure. So yeah, I definitely think that's probably something that you want to have checked. I mean, probably by somebody like me first. I think there's definitely some exercises that you could potentially be working on. We'd want to evaluate you and see if you have any mobility deficits that we could address, see if there's any strength deficits that we could address. And part of that's with the screen that I perform, especially for somebody that's having pain, that we want to do a good movement screen to see where you might have some issues that are leading to pain with the golf swing. And just so you can try and prevent that from becoming like a true chronic issue where it really bothers you all the time. So that's kind of what you want to avoid.
Yeah, I wholeheartedly agree with that. I think the proper, you can see there's a theme with Blake and I. We always want to get you into rehab first. So I think there's never a downside, and there's usually a huge upside to getting into a skilled PT like Blake. And there probably is little motion deficits that I pick up on a lot, and that's why I'm fortunate to have someone like him that he can kind of coach you through, and then hopefully you never even have to make your way to the doctor's office. So I totally agree with that.
Cool. Thank you, guys.
Mm-hmm. Hopefully we can come back and do another talk about hips and maybe lower back.
Absolutely.
That'd be great.
Yeah. Was there another hand raised? There's
I saw somebody was.
Yeah.
is it
Hey
Pat?
guys. Like Dominic, thank you guys for doing this. I appreciate it. Very informative. Like Dominic, I've got some lower back issues myself. In fact, right now I've got a nice little case. It's getting better. Case of sciatica, and actually doing some PT. They took some scans, and I just got a lower lumbar slippage, is what they've told me. But anyways, just wondering, what are some good resources to reference for, golf injury prevention or something like that might be able to take a look at.
Definitely. So the Titleist Performance Institute website has a lot of exercises and things that you can do. There's some articles on there as well about preventing lower back pain and that sort of thing. Just depends on how far into it you want to go. There's obviously a lot of medical articles and that sort of thing that you could reference as well, just with a Google search. But to me, what I would always tell somebody is it's just like your students, that you don't recommend that they go on YouTube and try and watch YouTube videos on how to fix their golf swing. I would kind of suggest this for you as well, that you probably don't want to dig too far into the Google and watching videos and trying to fix your own back. You really want somebody to take a look at it and see specifically what's going on for you that you can address. It's just going to be a lot more efficient, and you're going to avoid that potential of possibly injuring yourself further if you're doing the wrong thing.
Yeah, definitely. Okay. I appreciate it. Thank you very much.
Mm-hmm.
Sounds like back is a popular topic, because
Yeah.
so maybe that's one that we need to address next time.
Certainly something to think about going forward for sure. Any other questions? All right. Well, we will wrap this up. Blake and Elon, thank you guys very much for being a part of this. As we said, this will be recorded, or has been recorded. Will be edited and published in our weekly newsletter, as well as on our website, and our library that we are building of education for our members. So it's a great topic, and certainly something that down the road maybe we can explore some different areas of the body going forward.
Absolutely.
Of course. Thank you guys for having us.
Absolutely.
Yes,
Thank everybody for joining, and we will see everybody soon.